Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. My name is Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. So today I'm flying solo again, as I did in March, but it's a good reason. Our membership is enjoying our annual meeting in Savannah, Georgia, bringing you education on the business side of medicine to enjoy. So I am going to bring a topic that actually does focus on a couple of the sessions that were there, and one is making sure that your administrative tasks are being handled properly. And the one I'm going to focus on specifically is something that no medical practice or dental practice wants to get or likes to get, but it is inevitable that you will at some point receive what we call an ADR, or an additional documentation request from an insurance payer. So here is what that is. If you're not familiar with that, in the context of insurance, ADR refers to additional documentation request that is a request from an insurance payer like Medicare for additional records to support a claim. It's not a sign of wrongdoing per se, but rather a way to ensure compliance with policies and verify the validity of your claim. So it is an ADR is a request for further documentation to support that claim that you've already submitted. And this documentation helps to verify that the services provided are eligible for reimbursement, that they were coded correctly, and that they meet the payer's specific policies. And the last one is really important. I'm starting to see things out where AMA or certain specialty societies are recommending that providers do certain things and that I maybe find questionable. And then I look at what a payer policy is and they're like, no way, we would never do that. So this is where some of those ADRs come from. And why does this happen? So ADRs are issued when the insurance payer needs more information, not just to process the claim, but if they're questioning medical necessity, remember we look there first before they pay a claim, appropriateness of the service, and lastly, the coding of the service. But, as myself, as a coder, as an auditor, as an RCM person, coding is last. Medical necessity is first. Is it appropriate to even bill it? Now, what do you do? So when you receive an ADR, again, additional documentation request, you need to provide that requested documentation within a specific time frame, and failure to provide that documentation can and almost always leads to the denial of the claim, or they will ask for money back. A lot of times these come in prior to them paying you, so your claim is in a pending situation. For example, a provider might receive an ADR asking for a specific medical record to support a particular diagnosis or procedure that was billed. So they might need an op report or something. Common types: Medicare administrative contractors, max recovery audit contractors, so the RACs, they're common payers, third party, but they issue ADRs all the time. There's also limits on the number of ADRs the provider can receive based on their previous year's claims, so you always want to be up on that as well. If a claim is denied based on an ADR, you can appeal it through the either Medicare or the payer process, but first you want to figure out how do I respond to it and what's going on with that. So first, when preparing your documentation, the best way to first respond is to attach a copy of the ADR letter as the first page. So, and always take a copy of it. I had a practice that actually sent in their original. I was like, oh my gosh. So take a copy of it, make sure the documentation is matched to the appropriate patient and the claim. Providers and suppliers should submit the necessary documentation to support the services for the billing period being reviewed, and also may include documentation that is prior to the review period if they are looking for orders or, again, medical necessity to, do the procedure. Was it already ordered within the evaluation and management service prior to that procedure? So how do you send it? So it can be received from you, either U.S. mail, snail mail, your MAC designated portal, or it could be a RAC audit portal, fax, anybody still has fax, on CD or disc or digital video disc, or, they call it a universal serial bus, USB port. They have also something called ESMD, which is, again, digital way. Now, what are the time frames? Okay, so let's get started on some time frames. The reason that you want to know the specific time frame or timelines by different auditing bodies, or I should say different requesting bodies, is because if you miss these deadlines and you miss these time frames, then they have every option to deny that claim or ask for money back. So depending on the type of review, whether it be pre or post payment, and who is conducting the medical review, there are specific timeframes for the provider and supplier's response. So if it's a prepayment review, meaning before you get paid, and it is a Medicare administrative contractor, so that's your local Medicare, or it is a Medicare Advantage plan. Now this comes from the CFR 42405.903. Always want to give you the Federal Register, chapter verse. For prepayment review, it says a provider or supplier will be provided 45 calendar days to submit additional documentation in response to a contractor's request. Okay, so calendar days. So that also includes weekends. Prepayment reviews by UPICs. Now, you never want a UPIC. A UPIC means there's probably a whistleblower, and that you're pretty much in trouble if you get to that point. So again, outlined by the same citation I gave you, this is 30 calendar days to submit that ADR response. And then post-payment reviews, so both the first two are prepayment reviews. The post-payment reviews by MACs, SMRCs or RACs, so if it's a supplemental carrier, which is the SMRC, they also have 45 days. Post-payment reviews by UPICs, 30 days. UPICs, again, they want your money right now. They're just like, we're not messing around. And what if you can't respond in that specific time frame for that request? So the contractor may accept, documentation received after the 45 days, but you have to have good cause. And what have I seen for good cause? Natural disasters, interruption in business practices, other extenuating circumstances that the contractor deems good cause in accepting the documentation, but typically you have to request it. And they were much more flexible during the pandemic. Even some of the auditing contractors were putting things on pause, but those are back full steam, and I'm even seeing being doubled. And from what I saw from our recent and heard from our recent new Medicare administrator, so Dr. Oz, he said that he's doubling them. Now, for UPIC reviews, the contractor may accept documentation after the 30 days, but again, I'm not seeing that happen very often. So you need to ask if you need to extend. We do encourage providers and suppliers to work with your MAC carriers if it is Medicare. And what if you don't, respond to this? Well, again, under 42 CFR 405.930, it says that they have the authority then to deny the claim, recommend denial, or recommend a request now for reimbursement. Now, when you are dealing with TPE, which is Target Probe Educate audits, or CERT audits, which are done by algorithms, they're all done electronically because they see maybe an outlying coding situation in your practice, or all of a sudden you're cornering the market on a certain diagnostic that nobody else is doing in your geographic location. You also have some payers out there, like Optum, like WellCare, that again, they are not insurance companies. When I say payers, they're third-party payers. A lot of these audits come from insurance payers, but these third-party, auditing bodies or additional documentation request bodies, they tend to be aggressive, especially RAC auditors, because they're paid on percentage, not based on claim, but based on what they collect. And now I'm seeing, and this is why I really wanted to bring this conversation to the podcast this month, is I'm seeing a lot of these companies that are now, and I'm just going to call out Optum on this, is they're telling auditors to ignore the ADR if you agree there was a clerical mistake and just send the money back. I had or just let them take the money back, I should say. And that I don't like. I had a provider that had a new patient visit billed, and it was actually should have been an initial hospital visit billed. But the only thing that was wrong is the hospital designated the patient as inpatient, so it should have been code 99222. The provider billed 99204, a new patient office visit. And that's just a place of service, clerical problem. That was not trying to do anything that wasn't appropriate. The hospital place of service may not have been accurate. The provider used what he thought was correct, and that can happen to anyone. But not responding will set a precedence for that that MAC carrier or for that Optum, third party company to say they never respond, and now we get to, open up and even extend our audit or our search or our requests for additional information. Let's just really hammer this, provider who isn't responding. You need to respond. They always have portals. You can download any notes, any op reports, any documentation, any letters. You can even download, inquiries there. But also I'm finding, and I'm going to pick on Optimum WellCare on this one, they tend to quote Medicare Correct Coding Initiative or NCCI edits, they like to call them, incorrectly. I had another provider who had an office visit billed with a chest x-ray, and they said that the chest x-ray was billed inappropriately because it was included in the office visit due to NCCI edits. And that's not true. The National Correct Coding Initiative standard does not have bundling or inclusive edits for office visits and x-rays. So we were able to fight that with my membership clients. And not only that, we shut them down, but I charge them for our time. I'm like, this is ridiculous. So, and they stopped harassing that provider. So make sure that, you understand deadlines, whether it be 45 days, 30 days, and that you really don't give the power back to these, audit recovery contractors that they then feel like they can initiate recoupment proceedings if they are post-payment reviews, or they can deny your payment in reimbursement if it's a prepayment review. But the biggest reason I see denials on this is because these requests are ignored. And ignoring a request doesn't make it go away, okay? It's like noticing that you've put on 20 pounds and just ignoring it. It's not going away. You've got to take care of it. You've got to make sure that you are, being healthier, eating healthier, exercising, whatever. Same thing when you talk about your practice and some of these requests for additional documentation. It also can look like junk mail. And you want to open everything that comes to your office. And a lot of practices ignore snail mail now. They think everything is going to come by email and correspondence is just going to be electronic. But payers know that. And they like to, slide things in under the snail mail. And I probably shouldn't call it that, but the U.S. Postal Service. And so some of these, requests get ignored. The other thing is time flies in your office. And if you open it and you put it to the side and you don't hand it to the right person, and it has to be assigned to the right person who will address it immediately, follow through with the deadline, and also know where to find the information that's requested. That person should be someone who knows each payer, their policies, and also understands the process. So no matter the situation, when it comes to not just revenue cycle management, but the topic of today, additional documentation requests to be able to keep your consistency and your continuity in your reimbursement from your payers, it's important, it's imperative that this request is not ignored. Okay, thank you everyone for listening today. We always appreciate spending time with you each month to discuss hot topics on the business side of medicine. To find me or any of our amazing consultants within the NSCHBC, you can go to nschbc.org, click on the Find the Consultant tab, and we are easily accessible. You can look by first name or last name, or actually you can even check boxes on what we do. Lots of search methods. In closing, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics. We have a free webinar in June, outsourcing billing and keeping it in-house, June 25th, and that was with one of my favorite people, consultant Chris Sanger with Z Management Group, as well as the quarterly Medicare updates. My second quarter Medicare update webinar is on June 24th, so the day before. And for all educational offerings, go to the nschbc.org website, click on Upcoming Education tab at the top. You can also find all of these podcasts on any platform you listen to. We now are on 25 platforms. We've received several nominations for awards, and we're so happy that we're being recognized for podcasting in the business side of medicine. So again, we hope you join us next month where we'll bring you current and important topics on the business side of medicine. So make it a great day, a great rest of your month. And thank you for listening to the award-winning NSCHBC Edge podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org. The National Society of Certified Healthcare Business Consultants.